and jump in, even though we know other folks will start. This is Lisa Letourneau. I'm with Maine DHHS in the Commissioner's Office, and I'm joined by several colleagues, both from Maine and nationally, and we very much appreciate all of you taking the time to join to talk about behavioral health resources for supporting patients, people, and communities in response to the terrible tragedy of the Lewiston events. I want to start with a special thank you to all those who have been directly involved from those communities, and our hearts are broken and just go out for you. So we know it's been a difficult week, and there will be very difficult days and weeks and months ahead. So again, just thanks to everybody for joining and spending part of your time learning about how we can support all of you and in your work taking care of others. I am going to use a brief PowerPoint and just walk through a little bit about what we're going to do today. So just sharing this. Everybody can see. Can somebody give me a thumbs up? You can see.
Yeah,
great, super. So the goal of today's session is very much to provide support education to clinicians. So we realize this is potentially a wider audience, and that is totally fine, but Commissioner Lambrou had asked, there are many things going on right now, but if we could particularly try to find ways to provide support, education, and resources to clinicians who are caring for patients in the wake of the Lewiston event, and obviously statewide, share information on other things that are going on to provide support from state and community-based resources, and certainly try to coordinate with related efforts going on around the state. So as you all hear things maybe that other clinicians should know about, please feel free to let us know. This first session is being offered as part of what we're envisioning initially as 3 one-hour Zoom meetings over the next 3 weeks. We haven't crystallized yet the full topics and dates, times of those. They may well be at noon. We know no time works great for everybody, but we are recording this. We'll be sharing the recording and the slides, the presentations on a state website following this session. We are bringing in both local and national speakers and people with experience, starting with our very own Dr. Tony Ng at Acadia, and then also have national perspectives from folks who have experience with other mass casualties. We want to certainly leave time for discussion and questions, and then I'm going to just share a little bit about other state resources. So I mentioned today we have Dr. Tony Ng from Northern Light Health Acadia, who is going to start out with a presentation with his own experience and thoughts about responding to mass casualties. And then we're very fortunate to have Jennifer Borneman and Stephen Formansky, who are both with federal agencies and have experience with disaster relief, and they're going to share their thoughts as well. So with that, Tony, I'm going to stop sharing and turn it to you if you want to share your own slides and take it away.
Okay. Thanks. Let me see if I have here, make sure I can do this right. Bear 1 second. Okay.
You saw your slides briefly and then it switched to.
Oh, okay. So I need to, okay, I need to swap
there you
space.
Go. You got it.
You see it? Okay.
Yes, we're good.
All right. Hi, folks. So when I'm putting the slides on, I don't see your face. So I apologize for that. And thank you so much, Lisa, for organizing this, and also Commissioner Lambrou for championing this. It's unfortunate that I have, all of us have to be here to have this conversation, and I'm so grateful that the federal partners are here to help us out with this as well too. Just a little bit about my background. Besides my daily work here at Acadia Hospital, where I oversee some of the emergency stuff from consults and so forth, I've work experience working about 20 plus years in disaster mass casualty events, and I participate in several mass shootings, some as a responder, some as a kind of behind the scenes supporting the folks there. The last one I went to was Sandy Hook, so it's unfortunate that we, in a situation where we have this discussion to talk about what we need to do, and again, previous years we hear stories about the shootings everywhere, and Columbine, the Amish, Virginia Tech, and Sandy Hook, and there's a bit of wish that hope would never happen here in Maine, because it's Maine. We just we're different here in some way, but sadly reality came to us last week. So what I'm going to try to do is present at least an overview of what you may see, and may keep an eye out for, both from a system perspective as well as from individual clinician perspective. And again, it's really hard to try to touch on everything in the short time we have, and I presume there are going to be more trainings and more presentations about this. But I just want to really kind of put some key points for you to look for. First of all, on the disaster fact is that everyone who quote unquote see a disaster is touched by it, first hand, second hand, third hand. And in the state of Maine, where we are, I mean, it looks big on the map, but all of us know Maine isn't big. Maine is small. I mean, everybody knows someone from Fort Fairfield all the way down to Portland, and through some, couple of degrees separation. So even though this incident happened in Lewiston, I think many of us have some connections, our patients or people we know who are impacted by this, which is why it hurts so much. And the thing about disaster psychiatry, very different from trauma psychiatry, is that you need to look at both individual as well as the collective community trauma, which is what we have to do, because it impacts so many people in so many places. So other disaster factors, right now, some of the reactions people are having, the anger, the grief, the stress, I mean, they're very normal in a way. I mean, we are put in a very abnormal situation that had been very disruptive. And I think we are showing some signs that we think it's abnormal, but in essence, they are fairly normal within the scope of things. And in terms of the pattern, there's the disaster response, disaster relief, disaster chaos, and then the secondary disasters. Now, unfortunately for us in this particular event, kind of like other shootings, where it really gets resolved for about within like a few hours because of something happened, resolution to the shooter, we had linger for 2 or 3 days where a lot of things were interrupted across the state. People were anxious, they didn't know what was going on. Schools were canceled, activities were canceled. I mean, this was especially big on Halloween, because there were so many activities that kids were looking forward to, and these got changed. So it ripple effects across the board. Just people wondering what happened and how it impacts their lives, and it's not just to Lewiston, but everywhere. The important thing to notice, remember about disasters, is that it impact a whole bunch of people. You're at the tip of the iceberg, which is the disaster victims, the families, and so forth. But as you get further and further out, you have the families, friends, rescue workers, medical professional, and always public at large. And I think this is the important piece we got to think about, that even though the people you interacted with may not be in Lewiston, but there may be so many implications that they've seen this, they witnessed it, they know people from there, that they're going to be suffering from some sort of sequela from this event. Potential issues in mass shootings. First of all, there's the incident itself, which is, now it's over, but people are dealing with the aftermath. There's a death and injuries, but also there's this particular point, we in the stage where people identify victims and also do the services, arranging services. So it's going to be hard the next few weeks where people are arranging those services. And depending on where they are, I can't necessarily say they're going to be in Lewiston area. They could be anywhere in the state. And you get people from around the state traveling to these memorials, and I'm sure there'll be coverages as well. So I think it's an important observation or point that we get to keep an eye out for. Relationship dynamics, I throw it in there for other for big incidents, but the one thing about disasters is that it really forms bond between people, because when there's an event, people connect. So the people, they actually learn to have a relationship at the Family Assistance Center down in Lewiston and other places. People appreciate that relationship, but there's a secondary loss when everyone goes home. So I have had situations where people actually talk about how they missing that partner they had at the Family Assistance Center, missing the support was actually just as traumatic as the event itself. So I think it's important to appreciate that. There's also the uniqueness and isolation of the event. So some people, they have financial and job loss because they can't work because they're dealing with it. We have the post-incident experiences where there is, what happened afterwards. And then of course the anniversary, whether it's 6 months or a year. A year is always the tough one. So we have a year to really kind of think about what some of the issues are going on to say. Long-term tolls, social functioning, quality of life, and then also health problems related to ongoing stress. And some people may present not with psychiatric issues or mental health distress, but more physical complaints like You may know someone coming in complaining more GI issues or more sleep issues and things like that. And of course, you worry about discrimination, scapegoating. Particularly is the mental health, folks with mental health illness, because this is a big discussion right now. And I know the Commissioner of Public Safety made it very clear that mental health, psychiatric patients in general are not at risk because they're often the victims, but some people may still scapegoat them and go from there. So it's important for us to keep that in mind. And again, I'm not going to hit every piece of information on every slide because I believe you're going to get a copy of the slide. So it's a lot more for reference than anything else, but I just want to let you know. Now, who are the victims? You got the people physically injured, victims of the lost families, the people with witness traumas. I mean, the list goes on. And I really want to highlight the bottom one. People prior history of trauma is significant because what we're seeing now are people with trauma issues from before that's awakening because of this. And I think that's something we need to be aware of, people representing. So if you have existing patients, that's always a concern. And again, the reactions could be wide range, could be physical, emotional, cognitive, behavioral, and even spiritual. Now, this slide is the model of how do we look at disasters, what we call chronic cyclical disasters that we kind of create over time to, by vibrant mental health. And I'm not going to go through this whole slide because there's a lot of key points in there. And I just want to highlight two things on the slide. One is the different phases, which you see anticipation, impact, adaptation, and then growth and recovery. And I'll talk a little bit briefly about what each of those are. But the important thing to also watch out for this is not just the disaster you got to worry about, it's the bottom two, the foundation issues, and also the chronic stresses. People are already having stress from certain things coming in. They're not just brand new nothing and they're dealing with disaster stress. That is going to either push them toward having difficulties or, adding an extra layer for us to consider. Especially in the heels of the COVID pandemic, many people are still struggling from that. And that's not even just the community. I'm talking about even healthcare providers. So this is the part that we really got to appreciate as we're going forward over the next few months to a year. Again, these are the different phases. I'm going to show up in the different key points of each phase. Again, I'm not going to go through each one, but this part I'm going to go through fast because it's anticipation. So the disaster already kind of waiting for it to happen. Impact, we had the event. So what we're focusing on now is the adaptation. Now we're following through with where people are really trying to feel safe again. And well, they feel safer than before, but the challenge of safety has been there. I mean, people never thought this would happen in Maine because everyone gets along. We don't have those issues. We were just actually a week before this incident, we were listed as one of the safest states to live in. And to have that suddenly being kind of challenge in front of us, it is really tough. There's an initial surge of altruism. Everyone wants to help. I mean, you see everyone jumping into Lewiston, want to help out in Lewiston and elsewhere. And the energy is high. People want to do things, and then people working on the disaster assistance and so forth. Now, the growth and recovery is part that we need to focus on quite a bit as well. Well, start thinking about it anyway. We have to help people get back to normal in some sort of way. I mean, the disasters have changed us, but from past experiences, we are able to get the community back to some sort of normality over time. And this is what we need to figure out how to do that. There will be people also going away. The federal resources are going to go away. The initial goodwill, people will dissipate. News headline will replace it with something else. I mean, people will start feeling that forgetfulness, and people are saying, hey, no one remembers us. But I think it's important to let the community know that they're still very much in our mind, and we're going to do everything we can to support them, and looking at resources in general. Again, this is just another way to look at the disaster cycle. And right now we're looking at the post-disaster, and in some sort of way, we actually preparing a community to deal with the next event, whether that's, an act of crime, or act of even just nature that we have to deal with. Folks are going to be struggling with that. Now, this key slide came out of the Center for Traumatic Stress Studies for a while ago, but without going into detail, historically, we focus on the PTSD and depression, which you see on the lower left. And that's where, hey, we refer someone to psychiatry, let's see what medicine we got to do them, and that's fine. But I think there's a greater focus on how people react after disaster in terms of the distress behavior and human behavior in high stress environment. A lot of these things are not going to reach pathology level. A lot of these things are not going to come to the attention of psychiatric or mental health professionals, but a lot of them would come to what family members, school, primary care especially. So it's important for us to address this. So so some of the behavior may be people get impatient, people get impulsive, people have priority, they can't prioritize as well. They're shifting priorities. Healthcare and aid seeking can be impacted as a distressed behavior, not to the point of uh, causing a psychiatric illness. But example, there may be, as I said before, they may have greater concern for somatic concern. Oh, I have this headache, I have this GI issue, so I'm keep showing up to my, oh, I can't sleep, so I'm going to go to my PCP because I don't have a psych issue, but I have these things. So I think we need to appreciate that, that in almost every single event, whether it's shooting or not, we see some of that increase. So the important thing for us to do now as healthcare providers is really to want to educate ourselves. That's the important piece, but also start setting up surveillance. There's never going to be enough mental health providers in any place to see all the needs that's out there if we refer everyone as a sign of distress. So we need to basically set up layers of surveillance as well as interventions where they could be most effective and most efficient, because some of this intervention could be most effective at the school level. Some of this could be effective at the PCP level. It doesn't necessarily got to go to this high level of care because quote unquote it looks mental health. But again, partnership with community partners, faith-based groups is going to be important. What that does is also give you a sense of community. You're not doing this in silo. You're doing this as a partnership with everyone. And the important thing is it prevents burnout. We're all working in a very high stress environment now, even before this happened, because coming up COVID and just healthcare in general. But it's important we do this more now so to mitigate our own burnout and system burnout. And so therefore, integration is really the key to making this work. One thing I do want to touch on is social media. This is going to be big. I mean, some of you have seen the effects of this, not just with this, but everything in general. Rumors spread, misinformation, people trying to find, answers to their distress through social media. And, there's some benefit to that, but I think oftentimes it could actually generate more misinformation and misunderstanding of what people will go through, and even the stigma will go through about mental health issues and mental health patients. So it's important that we have those conversations with patients about what information's about how to help themselves and stuff would be helpful on the internet and social media. And sometimes being on social media constantly is going to be bad for them in general, because I think some point people want to connect because of this event, but they mistakenly thinking social media is that connection, and it isn't. So we need to reinforce other healthy ways for them to connect. I put this slide up there because it's important that when we design a response to social media, many people in hospitals have or clinics have social media accounts and have so forth. So you kind of put information up there and educate public, and sounds great. But an important piece to understand is how information is promulgated through the social media world. And this was a slide from a suicide talk that I did, and actually from a suicide study, where all these little lines of social media interactions. But as you can tell, the couple of dots, the red dots and the orange dots, are people, what they call, for lack of a better word, the influencer. People really listen to them. And this was catered towards youth suicide. So what they found was that these dots were actually a few kids who for some reason have the biggest influence on how other people react. So when we design a social media to help educate folks about the social health stress, it's important that we think ahead a little bit who we can use to really give us the most bang for the, for the buck with the message we're trying to get out. One thing I want to throw out there is what we call disaster victim identification, which is quite this, challenging, especially after mass shooting event. We are trying to identify victims. As many of you know, it's challenging because it's not like something happened, you get the remains quickly. There was a period where there was delay because some of the injuries are horrific, and also because it's a crime scene. It takes a while. What we saw in Sandy Hook was that people were upset because they couldn't get the kids' school bags for a week or two because they were a crime scene and they had to be processed. And I think we've seen some of that now. And these little things like getting a picture back, getting us some belongings back from a loved one, is extremely important to people to help recover themselves. There was also another incident about how to deal with those issues when, let's say, the victim is badly disfigured, and we've seen this in plane crashes, for example. And one example I remember two people talking about was this victim was so disfigured, but the only thing that was visible that looked normal was the hand with the wedding ring that was the family recognized, and they made it a point they could see that and touch that ring to have a formal closure for that person. So little things like that actually would make a difference and something for us to appreciate. The post-disaster stage is really where we are looking at right now. We try to encourage some return to routines. We talk about health and mental health surveillance. We need to start promoting more wellness routines, not just us, but everybody. We need to really work with organizational entities to increase support for ongoing mental health issues and EAP, or just support for staff in general, and also for corporations with employees. Continue interagency liaison, and then of course continue advocacy to support how we can take care of folks. I really want to put out there is the healthcare professionals, the first line responders. The issue of moral injuries, we are taking quite a bit from just our daily work, and COVID certainly put a big moral injury on everybody. And now on top of this for us, I think it's something that we need to be mindful of. My wife is a nurse, and telling her to take care of herself is, you know how that goes. So we are very good at helping others, but we don't do well at taking care of ourselves. And I think we need to shift that focus a little bit, because our work is basically a marathon plus the occasional sprint like a thoroughbred. So we need to constantly take care of ourselves, or else we can't do either one. It's a long distance race we're doing, and with occasional, busyness. The risk of continuous stress, high rate of negative coping behavior at work, and talk about the disaster stress behavior. People smoke more, drink more, eat poorly, overwork. People may want to work more because they want to forget what they're dealing with. That leads to turnover of staff. We are already struggling with turnovers, not just in healthcare, but in other businesses in general. And I think if we don't take care of our employees, we're going to get greater staff turnover, or people would just not do well at their job because they can't, function so well. And then, of course, the burnout. And then for the administration, they have to deal with all these things like disruption, staffing schedules, sick leaves, more negative public interactions, and I think some of that's going to happen. And then greater stress on, the ripple effect, supervisors and so forth. Coping skills, these are quick things: exercise, work, seeking support, spiritual care, and again, just some of the stuff, but not all of it. Again, I know I probably talk a little fast like a New Yorker where I used to be from, but at the same time, I was trying to give some information, and I really made this like you drink out of fire hose. And I know it's a lot of information, and but hopefully there'll be more stuff that give you the tools you need to do. So in conclusion, I kind of really want to say that there's a lot of lessons we learned in the past, and I know we're going to go through a lot of psychiatric, mental health stress over time. Some of it is normal, and some of it will require interventions of different sorts. The partnership is going to get us through this thing, and it's important to develop those relationships now, get the knowledge you need to have. And I think the one thing I always remind myself, I've been here 13 years in Maine. Maine has a lot of strong qualities, and I think what makes, I left here for COVID. I left here for, someplace else. I came back after COVID because Maine offers something that I feel other places don't as much, because there's that family, that connection, that everyone really take care of each other. This is what's going to get us through. And I think we need to tap into that as much as we can. And I think with that, we will get through this. So again, thank you for your time, your patience for the quick presentation, but I want to pass it over to Jen and Stephen from our federal partners, who can share their experience working in past mass casualty incidents and shootings and stuff. So.
Well, thank you so much, Tony. I really appreciate that. And I would just also encourage folks to start thinking about questions. Feel free to use the chat while Jen and Stephen share their perspectives.
Thank you so much, Tony and Lisa. Appreciate you. And appreciate all of you on the call. It is a true privilege to be sitting with you here today, and trying to support you any way we can from the federal level. Just to highlight some of the things that Tony shared, and we do, Steve will share some of his experience, but we work not only many natural disasters, but also mass violence events such as the Washington Navy Yard shooting and Umpqua Community College and others. So things to note, especially with you all who are so used to taking care of each other and taking care of everyone else. Now is the time to lean on each other, to be transparent about supports that you may need, or just being vocal about what might be helpful to you right now. I know that can be very, very difficult for this population, but as we all know, we can only be our best when we're at our best, and that means that we have our supports behind us, and that we're able to support each other and count on those who support us in the day-to-day. Now is the time to really do that. Something to think about in your various practices and wherever you practice your medicine is people are going to want to tell their story, whether they were immediately impacted or if they were throughout the state or even beyond. Folks want to tell their stories. That tends to be a level of comfort for folks. And so obviously that takes time. And so think about that, building that time in your practice, which I know it may not be easy to do, but maybe some other plans to consider that and how you would handle that situation where someone wants to share their experience, because that will happen. Of course, there'll be others who don't want to say a word, but a lot of folks will tend to want to tell their stories. Tony also mentioned that many folks come to you, as you well know, with a history of trauma. And so utilizing that trauma-informed approach to your work, I think is key, especially now when all their traumas are sort of rising in relation to what happened last week. So just something to keep in mind, and we could talk more about the trauma-informed approach after others speak. And just something to keep an eye on, and again, I'm a social worker here, is just be prepared for an increase in substance use, domestic violence issues, or intimate partner violence issues, and the like. And so however you can set up your practice to provide those extra supports for those who might be experiencing that on top of the trauma. I think those are some nuggets I had. Steve?
Hi, everybody. Thank you. I am Steve Formansky. I'm a clinical psychologist. I work with Jen and the other federal partners here. In my role, I've worked with ASPR, the Assistant Secretary for Preparedness and Response, for 17 years. This is my now 54th disaster response. So a lot of those were natural disasters, but more than enough were man-made disasters. So the very first one I went to was the World Trade Center bombing in New York, and was on the pile. I was a federal subject matter expert for mental health at Sandy Hook, Boston bombing, Umpqua Community College shooting. Went to Bemidji, Red Lake school shooting. So I've got some experiences there that we can share. And Tony did a great job in covering a lot of the topics, and he triggered a couple of thoughts, of which I wrote down some short notes worth thinking about. He did talk about social media, and I'm going to tell you one of the things at Umpqua College that we saw was, it's a community college, so you've got that age group generally, 18 to 25, but there's a range in ages. And with the social media thing, what we heard from the students, they were happy to survive and just scared, but happy to survive. But then on their social media, because that's where they kind of went for support, they were getting blasted, and things that they received were, maybe if you had a backbone, more people would have survived. Maybe if you stood up, more people would not have died. So I have to say that we had to quickly put out this message, and it's a crude message because it is a quick thinking, was about, your physiology is going to override your intention in these things. So, your physiology is to survive. So you're going to run. And you could almost see the change in these kids' faces when they were receiving these messages, because they were starting to believe it. Maybe if I did do this, maybe people would die. So we really had to do a very quick intervention through the school to reach out to the students and try to counteract that social message. So for you who are also parents, it's well worth monitoring the social media messages that your kids are receiving. The other thing I'm going to say is, out of the number of the incidences, I want to talk a little bit about an organizational thing. Some of the things I've seen, and this is more a message of where it can be destructive. So in the hospital, for instance, there will be a lot of attributions made about why is it that the ED sent this patient to the OR not prepared? Why did the OR send this patient to the ICU not prepared, or whatever? Why was radiology so long? And there can be lots of faulty attributions about that. And I can't say it I wish I could say this nicer, but when there's that chaos, the standards of care get compromised. And unless you're walking in their shoes, I'd be careful about what you're saying. Now, that's not to say you can't contribute to lessons learned and corrective actions, but there's some faulty attributions that are really going to create a caustic environment, and that's not what you need on top of a response. So I would be cautious about those things. I mean, and the fact is there's some truth to some of those things, and that goes into corrective actions, but it's chaotic and it's scary. And the one thing that we frequently hear out of medical people, and we heard this out of Boston bombing, out of the people, EMS folks at the tents, and hearing it already, is the medical people are going to wonder if they did enough, they did it well enough, and could they have done it differently? So when you start getting into those faulty attributions in that caustic environment, it just worsens that situation, because, even with internally, they're getting blasted. Honestly, find out what the truth is, and if you can walk in their shoes, maybe then you have a little bit more legitimate complaint, but be careful of that. The one thing on the trajectory is, Tony went through the phases, and one of the things is a bad statistics, but the bad statistic is typically it's 10 to 13 days post-incident where you'll have a copycat. Now, the copycat may not necessarily be in Maine, and it may not be the magnitude of Maine, but what happens is the people who are victims are going to re-experience some part of that and have some difficulty. So they're going to need some extra support. And what's going to happen is a lot of times, the victims, every time there's going to be a school shooting or a mass shooting, mass casualty event that raises to national level, they're going to have some, triggering experiences. So they're going to need some support there. Tony raised the comment about, and on his slide about personal belongings being returned. And, we do all these exercises around mass casualty events. And, at the end of the exercise, the dead get up and have pizza, that's not the way this has worked. And a lot of times, even in hospital incidences, but in shootings, the personal belongings are quarantined because it's a crime scene, but they also have to be sanitized before they get returned to the family. So that's a bit of delay. And in some cases, it's things like cell phones and keys and things like that. So it takes a while, and things that you take for granted are just disrupted now. And that's on top of the incident. You've got those disruptions, and how do you get home, and who do you call? How do I get my phone? It's got all my contacts. Those are additional stressors. I think one of the things that both Tony and Jen talked about is there's going to be these incidences that are going to be difficult to navigate and are scary. Having a connection is the best mitigation against ongoing distress. The thing we have found with that is be cautious a little bit with that, because sometimes what happens is the people you think you're going to get the help from all of a sudden look at you like you're contaminated, for instance. So, you still need the social connectedness, but also be prepared that some of the people that you may have counted on are going to react just a little bit differently to you. So go to the other source that you trust, and you are going to get your needs met. I'm going to stop there, and I think we can open it up to questions, comments, concerns.
I want to touch on two quick things, and one is people are going to be anxious about suicide risk after such an event, and certainly that's where the surveillance really got to come in. We really got to keep an eye on those things, but I also want to think about not just suicide, but just self-injurious events that doesn't get to that point. So people may find a relief because I want to cut, I want to numb the pain. I don't want to kill myself, I just want to cut. So I think it's important that we look at that for our vulnerable populations and a lot of teenagers and stuff like that. And we certainly need to implement better monitoring as well as interventions to support them, because some of them, it's the fact that they need to be heard, not necessarily need to be sent to a hospital, but need to be heard. It's why we need to help them. And I saw one of the couple of folks posted about the concern about inpatient beds. I spent my career doing emergency psych, and I'm the first one to not want to put people in a hospital because it's the most restrictive. Now, having said that, I do recognize certain people need it, and that's an ongoing discussion we continue to have. However, one of the things we also want to look at is really, do we have enough resources to divert people to other less restrictive, like, step down, crisis, all kinds of stuff that we could give people a reprieve without using at a high level of care? Because what do we need to do to support them? What do we need to do once people get into these settings? How can we get them back into community? Do we have the resources? Because if we don't, then you end up holding a bed and can't get them moving. So I think it's important that we look at the whole gamut. I mean, I know Acadia is going to be opening some additional beds because of that new building, but I think it's not just opening beds. I think we all got to be more efficient at how we use these beds and how to partner with other people that, can we have for certain folks who can go somewhere else? It doesn't need to hospitalizations. Again, ED has struggled with this for many things, not just mass casualty events, but in general, when health community resources, whether it's primary care or psychiatry, is not going strong. And we have to recognize that there is a pressure cooker there. There's a pressure point. And so, ASAP, which is American College of Emergency Psychiatry, and a few other organizations, Coalition for Psych Emergencies, are all looking at ways to reduce that quote unquote boarding that's happening. So that's a simultaneous initiative that's going on. And I think ASAP has some great ones coming up. But again, this is why I mentioned so much of community effort, that this is not just disaster-ish thing, but this is community efforts, community psychiatry, community mental health, and community health in general. How can we mitigate this ripple effects that's going to happen over the next month and weeks, months, even a year? So sorry about that.
No apologies. Thank you so much, Tony, and everyone again on the call, Jen and Stephen. Really appreciate your perspectives. Your last set of comments, Tony, I don't know if you were responding to the one of the comments and the questions in the chat, which was, are we going to be have the ability to increase the number of inpatient psychiatric beds in the state? And we know that's certainly been an issue to start. And as you've noted, Tony, there might be some potential for things that were already underway, like Acadia. It certainly, is a question, and I think we'll have discussions about that at the state level, but it's not going to be quick or easy, right? You can't just suddenly open mental health beds. So there absolutely may be a need, but I think we're going to have to, as you know, Tony, to think about the whole range of resources. I do wonder, though, both Tony and Jen and Stephen, in other communities, sadly, we are not the first one here, when there's been a need for increased behavioral health services, and particularly, here we are in the post-COVID environment where we already have behavioral health workforce shortages. This is happening on top of that. What have you seen other communities do in terms of meeting those needs, those heightened needs?
Communities will really kind of craft what they can. So there's not a single solution that we've seen. In some cases, what we have seen is bringing in behavioral health folks for the short term, outsiders outside of Maine in this area, such as federal providers, contract providers, the utilization of the compacts that exist, and bringing in people. With COVID, telepsychiatry or telemental health was greatly used, and that should continue. I'm trying to think of other things, Jen. I don't know if
an example I like to give for folks is about mass casualty events. Is imagine, this is Maine, almost everybody does it, is if you throw a stone into a puddle, a pond, you see that big plop, and then it ripples out, the waves goes out. And over time, that waves get increasingly less, but that middle part remains the most disturbed until later on it gets settled. What we see with these mass casualty events is similar. The community is grieving right now because that someone dropped a stone. It is a big plop of water and stuff like that. And over time, that ripple effect is going to get less because some of these issues will get merged with everything else. Like in terms of I'm dealing with job stress, I'm dealing with everything else. So it's important that we tease out those things that maybe even a year from now, even though someone may come in, we should explore if there's any connection to Lewiston in some sort of way, because was the stressor point for them started in October when this thing happened. So it's important to look at those things. But certainly for the people who are directly impacted, and certainly for Lewiston, that middle part is going to be the heaviest in terms of the response. So we just need to be mindful of that. And again, people move around the state. So people in Lewiston now may move to Presque Isle in 2 years. So now you're going to see the stress they're dealing with Presque Isle. So I think it's important that, again, we want to talk about the risk and stress and people going through and whatever help we can give them, but we also need to factor in the other side, which is a lot of people going to get through this, and we're going to support them and how they can also support the other people to get through this, and how do we maximize that. So again, I think over time that the tension is going to get less and less, but again, there's always going to be a core group that's really directly impacted, and even those after a few years, they're going to start feeling other stress, life stress coming into play, and that may impact them. But again, from our perspective as care provider, we should always try to get a timeline if we can to see how this correlates with their presentations.
One of the other things that we've seen, and this is kind of piggyback a little bit on what Tony just said, is you have to tease out, and there's got to be a little bit of an assessment. There's going to be people who are grieving, and that's different than mental illness, and it shouldn't be thrown in as mental illness. Now, you can say at some point, there's a new diagnosis of prolonged grief at the year mark. That's important to track, but people who are crying or having some difficulty now doesn't necessarily equate to a mental illness.
Other questions if folks want to either unmute, or I'm seeing another one in the chat here. And folks, again, feel free to unmute if you would like, but it's from Cindy, lived in Newtown during Sandy Hook, provided free trainings. Cindy, do you want to talk?
Sure.
Here we go.
Okay. I'm Cindy. I am a licensed marriage and family therapist. I work as a school counselor at North Yarmouth Academy now. I lived in Newtown during Sandy Hook. And when I was a recovery support clinician from 2014 to 2017 over at the school, providing support to the teachers who were there. There was a separate person who provided clinical support to the students, but it is very much a challenge because you have so many different people, and the gentleman was correct that there isn't one sure solution to this, and everyone has their own approach to what is healing for them. And that was something that I had found to be very challenging. But I will say that providing EMDR training to clinicians for their clients was extremely helpful. Many of the survivors of the mass shooting in Sandy Hook found their EMDR to be exhausting, but extremely helpful, especially during the anniversary times of the year. And then there was also, in terms of like social connection, we had a program called Ben's Bells Project that came in to our community from Arizona. And they have a Kind Campus initiative that any school can register and sign up for that. Hearts of Hope is another organization that a lot of community members created connections with. So it was just, arts and crafts that created a positive message and giving people who felt very hopeless, some initiative and empowerment of things to do. So those are a couple of things. We also had some positive speakers come into our community. Bruce Perry was speaking to the school district, and we had Bessel Vanderkolk come in and talk to clinicians. So those were, a number of things that were very well received in the community.
It's great. Sorry to hear you lived through that as well, but thank you for sharing that. I also noted Catherine Ryder, who's the fearless leader of Tri-County Mental Health Service, who's right in the very much affected area. So I didn't know, Catherine, if you wanted to share any thoughts about how things are going there, what you're doing for providers, other thoughts you might have for other communities.
Sure. Thanks, Lisa. And thank you, everybody who has reached out to us to offer your support. I cannot begin to say how amazing it was to have the outpouring of support, not just from across our community, but the state and the nation as well. So things are going quite well, all things considered. We've had some excellent collegiality between Sweetser and Tri-County, who have been front lines at the Ramada over the weekend, and then are gearing up to assist and provide support for the Community Resiliency Center, which we hope will stand up at the end of this week and create one point of contact for folks in our community once the Family Assistance Center at the Armory closes down as well. And to my understanding from the debrief yesterday, our FBI colleagues will be leaving the state of Maine Thursday afternoon, and much of that work will transition to local providers. I would offer to you that I think one of the things that was exceedingly helpful was that we had options co-responders in our local project support use staff who were fully embedded with EMS and law enforcement and have been for some time, who were able to respond immediately and in a different way than the training that we traditionally provide to clinical staff. And in a disaster behavioral health situation, and I was fortunate to be trained for disaster behavioral health years ago with the Red Cross, it's a different intervention than what we historically do in clinical outpatient services. So, our teams rallied, and with the support of Crisis and the exchange of what services needed and who does it get directed to during those first early hours, there was some really good collaboration going, and I think we got to many people early on. I also want to give a shout out to our comfort dogs. I don't know if anyone saw the photos of the dog teams that came in, but we had canine first responders available. They've worked with first responders, law enforcement, community members. They were at the vigil the other evening at the Basilica. And for folks who couldn't use their words to express their grief, being able to snuggle these animals, some of them tiny, some of them ginormous, was tremendous. And we continue to activate them within the schools and other organizations across the community. So if you're looking for successful interventions that don't involve narrative therapy, take a look around. We have lots of organizations that have stepped up to the plate that are offering those services, and I'd be happy to help you make connections.
I just want to add, Kathy, thank you so much for the work you guys have done. I mean, you guys were in the thick of it right in the beginning, so wonderful for you. Appreciate the efforts. But you also, I want to emphasize the point that you hit. One of the things that stress people a lot during a disaster recovery process is the lack of information, the consistency of information. So if there's a way, like what you're doing with the center coming up, if we can make sure people get the information they need, that is a tremendous help in so many ways in terms of resources and stuff. When people are under stress and you say, well, why don't you go and find different resources? And people can't do that. And I mentioned about distress behavior, about people just shifting priority. They can't, they need help. So I think something like that is extremely helpful. And that's not even for general population. I think someone made a comment about the folks with hearing disability. A key point. I mean, they unfortunately they got hit with 4 victims who were from that, but people with, whether it's hearing impairment, visual impairments, we all got to remember those special population have needs that we need to address, and that's why the one size fits all is not going to work. So we got to be unique about it. So
that's exactly right. Yeah. And there have been interpreters on site since the early hours of this event. Director Squirrel has been front and center in helping to navigate conversations with local, state, national leadership. And I think there will likely be communications released in the very near future about the Resiliency Center.
Great. And, I'm going to, I don't at all mean to cut off this conversation, but just because we're in a few minutes, I want to just flag a few things in terms of resources for folks. So we will share both the recording and the slides from this on a page that links to one of these sites. I don't have that totally yet, but just so folks know, we have posted a DHHS behavioral health resources webpage, as well as the governor's page called Healing Together that has a whole list of different resources. And then there's also a brand new online DHHS online request form for organizations or communities who want to request support with behavioral health counseling, training, connections through a link to this online request form. Again, I will send this out to everybody who's registered for this, and then we'll have it posted on a state website as well. But there are at least initial attempts to try to organize some of those information on those resources. We've also try to stick to some consistent messaging out in the public. You've seen some of this about 911, 988, resources for youth, the helpline, warm line for clinicians, and then 211. There are also other efforts going on. We're again trying to just stay aware and coordinate to the extent we can. So the Maine Academy of Pediatrics has a terrific training coming tonight. There's a link here. If somebody, Amy, could you put it in the chat if you don't mind? The registration for that's with another organization, I believe called Vibrant Health, about caregivers for children, so psychological first aid support. The Maine Pediatric Behavioral Health Partnership has actually has an ECHO program going right now at the same time, but their website has a lot of information and recorded sessions, including a Trauma-Informed Care 101 that's a recorded session. There is the Red Cross Guide to Psychological First Aid that's out there. I couldn't, unfortunately, get the link for this, but we will post that eventually. And then the Maine Association of Psychiatric Physicians has a lot of volunteers providing support. And then they have a consultation project that's been existing that offers one-on-one consultation for primary care providers with psychiatrists, volunteer psychiatrists in the state. So lots of others. In the slides, I've got a lot of the contacts here at Maine DHHS as well. So let me just get off of that and go back to any other questions or comments. There's several things in the chat. Anything anybody wants to call out here, sorry. Or feel free to unmute. I couldn't see while I was doing that, but other things that people want to call out. Here's one for you, Tony. I wonder if Dr. Ng could explore in more detail the initial response of caregivers being altruism and how that shifts and evolves over time, seeing that process play out with other colleagues, thinking how to enable altruistic acts for the caregiver's own well-being. you want to say anything about that, Tony?
Yeah, I think, first of all, I mean, that's for better or for worse. I mean, we really care about what we do. That's a big degree of altruism that we all have, that we want to help our community and help, others. And I think that's why we're so feeling so strong. We got to do something now to help others. I think a couple of things. One is, it's important to recognize that you do it with organizations, because one of the things, like, we've seen where people went on their own, and because they feel altruistic, actually make things worse for the response, because no one knows what they're doing and stuff like that. But I think it's important that we set up a tier of a layer of help, because as much as we want to help, this is a long-term affair. This is not just the next week or two. We have to have that the ability to help others. And we have to channel what we can do best to help them. As much as, this is psychiatry, we're talking about account transfers all the time and all kinds of stuff. But, yes, we all have special skills. Where can your skills be the most effective to help the people? And that's where we want to balance that along with our urge to immediately do something. Not to say you're just sitting on your laurels and not doing anything, but it's just saying that you can support most effectively because of your skills. Everyone on this call has special talents and skills that they can contribute so much to their community over time. And that's where you can maximize some of the altruism. This altruism is not just inherent to us. I mean, everyone wants to help. And sometimes, by the way, this is where the honeymoon period is nice, because everyone wants to help, but the honeymoon is tough when everyone goes home. When everyone goes back to the thing, and people in Lewiston say, well, or people anywhere says, like, now we're back to fending for ourselves. But again, what I like about Maine is the fact that, yes, that may feel that way, but we don't act that way because we continue to help. And I think, one of the things that's established now, initiatives that we all can participate in. How do we work with our communities? Because, oftentimes when we look at the far distance where the effects are, but we forget that tons of people around us who actually need care, and they need us right now. So.
Okay, one more question, then we're going to have to wrap. Probably a military connection. How do I help a fellow soldier? Anybody want to speak to VA resources, Amy?
Well, I was just going to say the Maine VA has been putting out resources to those enrolled in the VA, but you could also contact Togus VA and they could get you connected to resources. I think on the governor's website, they're also going to be adding additional resources for veterans. They're working on that right now. They've added to the governor and the DHHS website resources for the hard of hearing community, as well as the different ethnic and community-based organizations. So they're working on filling out more resources for the veterans. But if you need help, I would go to the Togus VA and ask for assistance.
Yeah. The Center for Center for Study of Traumatic Stress and Uses. That's a great resource, and we can probably share that at some point. I mean, there are tons of fact sheets, tons of information, and tons of guidance for lay people as well as healthcare professional, and that's part of the uses, the part of the military university. So I would certainly suggest that's a great resource for people to go to. Sorry, Catherine.
Catherine, did you want to add?
Oh, sure. Sorry. I would also offer that our CCBHCs, as one of their domains of service, will offer supports to veterans. We have a veterans outreach coordinator here that is tied to every veteran resource in the state. We welcome your calls to that number. And then the veteran centers and the CBOCs across our communities are also excellent resources. I'm sorry, CBOC, community-based outpatient clinics.
Of the VA, yeah.
Correct.
Of which the VA has something like 8 around the state, I think.
That is correct.
Yeah. And then Cindy's noting veteran centers are also available for veterans. Cindy, do you want to, I don't know what veteran centers are. Community centers?
There's specific veteran serving organizations not tied back to the VA.
Okay. All right. Well, we are at 1 o'clock, so we're going to need to wrap, but really appreciate again everybody's willingness to participate in this and take the time. Again, I will send out both the slides and other resources noted today to everybody who's registered for the call. We will have more coming, and we'll be back in touch with more specific plans on subsequent rounds of webinars like this. We hope you found it helpful. If you have any suggestions, feel free to email me or Amy or any of the folks on the contact sheet in the last slide directly. Thanks again so much, Tony and Jen and Stephen. We really appreciate your help as well. Everybody take care of yourself first, and so appreciate your help in taking care of patients and communities. Thanks.
Care. Bye-bye.